Good afternoon. We'll just wait a few minutes for people to join. Hi, Sarah, as well. Hi.
Hello.
So today we're going to be talking about the science of human factors. Um, so if you could just let me know in the chat how comfortable you are with the topic of human factors on a scale of 1 to 5. 1 is I don't know anything at all, and 5 is it's part of my skill set. Two or 1 to 2. Okay, great. So, okay, good. So just going to share the screen and okay, here we go. Science of human factors. So we're going to talk about human factors, what they are, how they apply to healthcare, and how changes in the processes can mitigate the effects of these human factors, and some ways in we can think of what things we can improve to get around human factors, and also what part technology can play. So why does it matter? Well, it's a bit like somebody who does infection control doesn't understand microbiology. It's pretty fundamental to creating a safe environment, because our workforce is people, and people make the system work, and um, humans are prone to error, because we have brains that can make up things and make mistakes, and communication that is never 100% between one person and another. So there's all sorts of places where things can go wrong. We've talked about errors before on a previous lecture. So just to recap that, errors are either things that you do, but you do it incorrectly. So you you try and do something, but you didn't quite do it as you wanted it, or as you intended it to happen. So those are mistakes. And then, sorry, those are slips and lapses. And then the other type of errors where you choose to do the wrong thing. So you choose to do the wrong thing, it goes as you plan, but then the result is not what is wanted, because it was actually the wrong thing to do in the first place. And out of those mistakes, one is rule-based, so you've got the right knowledge, but you put it together wrongly. So you took two and two plus two, and you got 5. And a knowledge-based mistake is where your fundamental understanding of the system of the thing is wrong, or there's a lack. So when we're trying to make decisions, there are basically two ways in which humans make decisions. One is automatic thinking, which we may also call subconscious or unconscious thinking. It's a really rapid decision-making process, and it accounts for a lot of the decisions we make during the day. Apparently, we make something like 10,000 decisions in one day, but you're probably not aware of that because a lot of that is automatic thinking. Just I think you would be how tired you would be if you actually consciously were making 10,000 decisions. So the conscious decisions are the controlled thinking. That's the things where you think through a problem and you come up with your decision or your solution. The problem with automatic thinking is that it's prone to errors of execution. So you might do something so quick and you kind of miss the target slightly. The other thing is that you might not notice key bits of information to land up with the correct decision because you're going too quickly. And so you miss important information and you end up with the wrong decision again. Controlled thinking takes a lot longer. It's more effort, and it can arrive at a better result. But the downside to that is that because it takes time and effort, you might not do it to a high enough quality, and so you make mistakes in that process. Okay, quick question. Is there anything here you wouldn't drink? I'm going to give you 5 seconds to look at this. Right, now put it in the chat. Anything there you wouldn't drink? Good. Tide, that's right. And the reason you spotted that is because it looks like a bottle of detergent. But the problem is, did you also spot baking soda down in the right-hand corner, which looks like, you know, maybe a jar of jam or something, but it's not something that you would want to drink. So what you were using there to decide what is drinkable or not is called heuristics. So these are mental shortcuts. You've seen patterns in the past, so you know what a drink kind of looks like. You've got a mental model of that. And so when you haven't got long to look at something, you use those heuristics to make quick decisions. And you were able to spot that Tide does not look like a drink. But when something looks similar and there's only one difference, like the name on the front, then heuristics is going to miss that. So other examples in healthcare of heuristics is if a doctor sees a patient in ED, and because they're so rushed that they have to make a very quick assessment and they just dismiss their condition as being drunk because they can smell them and they've seen them before, they come in before drunk. But actually this time they come in with hypoglycemia and that gets missed. Which is why we now routinely take sugar tests on anybody coming into ED, who are coming into majors anyway. So that's one. And then a pharmacist picks up the wrong medication box and delivers that because the packaging looks quite similar. That's heuristics again. Or a nurse who stops noticing critical alarms because there's lots of things going off, buzzing off, and most of the time they're false alarms. So then, and you hear another one, but you automatically dismiss that alarm even before it's come into your conscious thought. And that's why you just don't notice it. Okay, so what factors make errors more likely to occur? So there's obviously certain situations that are riskier that are going to produce errors, you know? So can you think of a few examples of a few reasons why those last three examples were going to happen, those errors were going to happen. What sort of factors could contribute to those errors happening? So I gave you one example of a physician who's in ED, busy, pushed, and they have to make a quick decision. So can you think of other factors, environmental factors or patient factors or staff factors? Just put it in the chat if you want. Tiredness, distraction, stress outside of work, a seemingly more urgent situation taking place at the same time. Yeah, these are all really good examples of factors. Good. So yeah, you can think about internal factors and external factors. So internal factors would be, as you say, things like fatigue, stress, hunger, illness, attitude, memory, things going on at home, totally unrelated, that is preoccupying your mind. You know, you might be going through a divorce or something that's quite stressful. So those are all internal factors. And then external factors are things like environmental forces, noise, light, temperature, work schedule. So yeah, I mean, like simply an working environment that's too hot will make people distracted, or simply somewhere that's too cold as well, you can't really concentrate. Then there's other things like training, rules or procedures, distractions, language barriers. So all these can contribute to errors. And then the last thing there is cognitive biases. So that's what we are ourselves are more prone to do or decide on. So we each have our individual experience in life. We have our own upbringings. We have experiences that have taught us how to cope in life and stuff like that. And we have experiences at work that have taught us, okay, this thing gets a good result. This thing got a bad result. I got in trouble for this, and all these add up to what's called cognitive biases, where you're more likely to choose one thing over another in the future simply because of your previous experience. And that is both a good and a bad thing, because your experience may be experiences which are representative of what usually happens, and therefore you're likely going to make the right decisions in the next time that happens, because it's usually going to be the same thing. So your biases are probably going to help you in situations where it's common and your experience was a fairly normal experience. But if you've had previous experiences which are not quite what most other people experience, but it's your normal, then you start applying that to situations. It's often going to be wrong. So confirmation bias would be one thing, where, for example, a doctor has had one patient die in the past because of a complication that they missed, and there was a subtle finding on an X-ray that they missed. Then they start looking at the X-rays of future patients, and they keep picking up that subtle finding on the X-ray because they think it's the same thing, but it actually isn't. So that's confirmation bias. So how can we prevent errors knowing all these factors that are at play? Well, we can work hard and we can try our hardest and be vigilant, and that can be effective to some point. And probably the the biggest thing is if you've had a bad experience in the past, you're less likely to make the same mistake again just by pure vigilance and remembering the bad experience in the past. But the problem is that we're only humans, and you can't sustain 100% performance just by trying hard and paying attention, because of all the other external factors that might not even be under your control. So this is where human factors engineering comes in. It's trying to control all these factors so that it's almost impossible to make the wrong decision or the wrong mistake. And if it is made, then it's picked up early. So the principles come from anatomy, physiology, physics, and biomechanics, and all these things that help you understand how humans behave and what makes it easy for them to do things physically, and what makes it difficult for humans to do things. Oh, sorry, hang on, I lost it for a second. So here's some examples of changing systems. Probably one of the biggest successes in modern medicine is anesthesia. So when people are when patients come in and they're scared to undergo an anesthetic, it's actually because of historical experience with anesthetic. Like we're talking 50 years ago, where there was a reasonable chance that you would not wake up from the surgery. But that sort of story has been perpetuated in media and stories and TV and movies. So the public perception of anesthesia can still be that there's a reasonable chance of dying. But actually now in reality, the chance of you not waking up after surgery is extremely small. Now, how have they managed to achieve that? Well, it's been incremental changes to everything over those years. It's standardizing those anesthetic machines so that the valves turn in the same way to turn up the oxygen. And that was because of previously there was a death that happened when an anesthetist turned the knob the wrong way and turned all the oxygen off, and the patient didn't get any oxygen. And that was a stupid error. But now the knobs all turn in the same direction. They also have employed lots of checklists. So anesthetists at the beginning of the list, before anything happens, them and the techs, they run through a huge checklist to check the anesthetic machine is working and all the backups are there, etc. A bit like a pilot checks the plane before they take off. And that's avoided people just remembering to make sure it's all working. And then the other thing that they've done is really worked on actually the communication and teamwork, by trying to flatten the hierarchy so that there's less of a barrier for people speaking up, encouraging teamwork with nurses and anesthetic techs, and trying to reduce the all the burden on one single person. So it becomes much more of a team approach to anesthetizing the patient. And lots of training on those human factors, on how to deal with the team and get the most out of the team. And again, a lot of that was taken from the airline industry. So that's an example of changing system just step by step. So there are many ways to try and prevent errors. You can simplify things, so just make things a lot easier to follow, reduce the number of steps, standardize things so that it's the same wherever you go for the same thing that you're doing. And standardizing across a whole health system is probably a really good idea for things. And an example of that in New Zealand would be the observation charts, which are now all the same across all the hospitals, with the same early warning score system on them. Avoiding reliance on memory. So those are the checklists. Probably the most famous one would be the WHO surgical checklist, which was started up by Atul Gawande in America and is now in almost every hospital in the world. So that's not only developed nations, but also developing nations. In fact, that's probably where it has its best effect at preventing serious errors in surgery, such as operating on the wrong site, doing the left instead of the right. And the other one is preparing for blood loss and making sure there's blood available, which in a country like this is never really an issue. But if you're in Africa and you're going to undergo an operation with 4 liters of blood loss, if you started the operation and then there's no blood, and that patient will die. So that's where a checklist really comes in to make sure that you're not missing some serious problems. Improving access to information. So this is about trying to make sure that key bits of information are in front of the person who's making the decision at the time they make it, which is where computer systems have really improved over time, where they provide you little snippets of tips just at the right point in time when you're actually interested in reading that. Before, it was just like pop-ups that were really annoying, but now they're getting better at actually giving you tips and tricks exactly when it's important. And then also improving access to information by, online systems, and all that gives you the patient information at your fingertips. Taking advantage of habits and patterns. And probably the best manual to doing this is actually James Clear's Atomic Habits now. That really breaks down exactly how you can make humans do things very consistently and automatically. And well, that's another topic for another day, but his system is really, really impressive. Forcing functions is something you might hear a bit. So forcing function is creating a product or a piece of equipment or the environment where it becomes impossible to do the wrong thing. And for me, an example of this, the most famous example would be in the UK. There was a death where a lady came for oncology treatment, had to have 2 types of treatment, one into the veins and one into the spine. And the 2 different types of chemotherapy needed to go into the right places. But she unfortunately got the wrong drug into her spine, and that killed her. She died. And so from that, there was an inquiry, obviously, and then they worked out that, well, it was possible to fit the syringe onto either the IV line or the spinal cannula. And then they changed all the connectors so that it was impossible to connect the syringe to the spine and vice versa. And that is an example of a forcing function. Visual controls, that's an obvious thing. So like just making it more obvious. Promoting effective team functioning, I've talked about that in the anaesthetist, and using redundancies. So that's if one system doesn't work, then there's already something as a safety net underneath that's going to stop actual harm happening. Eliminating external factors that degrade performance. So another thing would be nurses' drug rounds. So nurses who are wandering around with the drug trolley trying to give medications to patients, they need to concentrate to put the right pills into the little pottle to give to the patient. And if they get interrupted by other members of staff whilst they're doing that, they will come back and they might forget where they were on the drug chart and maybe and say, oh, did I put paracetamol in there or not? And all the pills look the same. So they think, oh, I didn't. So they put an extra dose of paracetamol in there, for example. So trying to prevent them getting interruptions. I don't know if it's worked, but there was a vogue for a while in hospitals of making nurses wear this big red tabard that said, do not interrupt me because I'm doing drugs. And I always laughed at it because nobody everybody still kept interrupting them because people were too busy to wait. And then it just made them look like they were wearing this tabard as a punishment, because a bit like wearing a dunce's hat. It looked like they were being punished. Anyway. So I don't know if it actually worked or not, but that's always a problem. And then create systems that are better able to tolerate errors. So if you do make a mistake, it's not the end of the world sort of situation. Okay, so here's some more examples. Double checking someone's work, a computer alerting someone of a potential error, removing a step in a process, storing things that are used together in the same place, a system that requires a piece of information to save your work. So what are all these examples of? Well, double checking is using redundancy. The computer system alerting, that's building a system that can tolerate errors. Removing a step is simplification. Storing things that can be used together in the same place, that's taking advantage of patterns. That's in line with James Clear's laws of habits. Forcing function is the last one, where you need a piece of information to save something. So a lot of people always think of technology when it comes to trying to prevent errors in humans, because a computer doesn't forget. A computer is 100% reliable. It will produce the same result every time. However, technology can do that, but it often brings in other problems. And the reason is that there's always an interface between technology and humans, and you're never going to get rid of that interface until you have a situation like the Matrix or Terminator. So, yeah, we just need to be mindful of that whenever you're thinking of technological problems, and you will always, at best, a computer will solve one problem and it will create a new one. And then you just have to ask yourself, which of the two is the less of the evil? Examples are electronic medical records. What is the problem that the electronic medical records have solved? Missing notes, and notes not being available in clinic because nobody's managed to find them or pull them in time from the notes department. The other thing is that if two people need the notes at the same time, that's possible electronically, but not with a physical set of notes. So they have, and also they solve financial issues such as, the amount of space and money it takes to store these paper notes and then shuttle them around the hospital. That's all been saved by electronic medical records, but it's created new problems. So, for example, we don't have enough computers for people to access these medical records. So people either have to wait and delay their work, or they simply just try and do it from memory. And then, of course, then leads to human error from using memory instead of what was in the notes. For example, electronic medical records are less easy to use, less flexible to use. There's nothing easier than a bit of paper and a pen for recording whatever you need on there. And if you want to develop a certain performance stuff, paper is still really easy. Whereas the electronic medical records, they're very difficult to change, require quite a bit of IT support, etc. So you can see one set of problems solved, another set of problems created. Other examples, barcoding to help identify patients and pieces of equipment, order prescriptions. So yeah, we've got electronic charts, medical charts, and again, that reduces errors of prescribing wrong doses and stuff like that. But again, it introduces problems such as access to these charts. Yeah, so they're not a panacea. So really the best practice is not to jump to a solution or think, oh, a computer can solve this, but to really think about the whole problem and design a process that is going to be better, not just a computer or a specific piece of equipment, but to think of the whole process from start to finish and how humans interact together and interact with technology at every stage. That's how you get to really improve things. You need to test things out and need to look for places where people are circumventing the process that you're wanting them to happen, i.e. workarounds. So doing things the way it's not supposed to be done, but because people worked out that's the easier way or it's the only way because there's no resources to do it the right way, for example. So looking for the workarounds and trying to either use them and build them in or try and prevent them happening. And we still need to make sure that, there's plenty of human processes going on, like double checking, etc. Because of course, technology sometimes just altogether stops working and the servers stop working and stuff. We need to go back to a manual process. So now we're going to watch a video on this. So I'm just going to play that. Can you hear the sound? The thumbs up if you can. Okay.
Welcome. This is part 2 of our reliable design methodology. In part 1, we talked about why we have reliable processes and what we need to do to make them reliable. Now we're going to talk about the methodology and how you can begin to apply it in your processes. The first is to start small. That is, start with a subset of your population. We know that in all situations the same process won't work for every patient, so we have to figure out which ones work best and how do we apply them in the context of the care that we're delivering. We also have to design the process that is the easiest to work with. That is, we don't want to add complexity to what the caregivers are doing every day. So we're going to simplify that process, make it as easy as possible to do the right thing. And ultimately, by starting small, you can learn about what works well in that population, because if you can't get it right in that population, what makes you think you can get it right in the rest of the population? So learning will help you grow and spread your processes to other populations. What is a subset or a segment? It should be a group of patients that are easy to identify. It should have willing participants on the part of the healthcare providers who are willing to work with you to test new methodologies, to test the way you want to design the process to make it more reliable. You can learn from that subset so that you can continue to expand and spread your work. And the subset has to have enough volume that you are able to test daily or every other day. And what we mean by that is that if you are not able to test daily and you can only test once a week, you can only learn once a week. If you run your tests daily, every other day, or even multiple times in the same day, each one of those is an opportunity to learn, and so you can move more quickly in your improvement processes. An example could be patients in one ICU, or it could be just Dr. Smith's patients, for example. Or it could be just patients in one clinic of a large clinic setting. Or it could be just male patients over 65 who are coming in for a particular screening. Those are all examples. Now your subset you have to examine, because if it's too large, then you need to narrow it down a little bit. If your subset crosses many areas of care, that is many clinics or many units, many wards, then that's going to be a challenge too, because each unit has its own culture and its own challenges, so you want to try to limit it to just one area. But just remember that it has to be volume large enough that you can test daily or at least every other day. The next step is to visualize the steps in your process. We ask you to draw a flow diagram of 3 to 5 boxes, no more than that. Some of you may be familiar with lean methodology or others that ask you to draw this very complex driver diagram, and there's nothing wrong with that, but it's really complicated, takes a lot of time, and we want you to visualize very quickly the 3 to 5 steps that are in your process. Now, the 3 to 5 steps may look different from one hospital to another or one ward to another, but it's conceptually what the process looks like for you and what needs to happen. And then within those, identify the defects. Now think of, is there a possible cascade? That is, if we don't do the first step right, it doesn't matter how much we make the other steps more reliable, we have to make the first step right. So let's take an example of what I mean. If we are developing reliable processes for managing a patient with a pressure ulcer, but we don't have a good, reliable process to assess the patient for pressure ulcer risk, then we can develop all those processes, but we don't know how to best to apply it because we haven't identified the patients for whom to apply it. In that case, the flow diagram would point out to you that the first step should be, let's make sure we have a reliable assessment process. You might also identify which is the biggest defect that we need to work on, because if we can fix that defect, maybe we can make the rest of the process much more reliable. And from there you can continue, because you will have to work on the other steps in the process as well. This is an example of a high-level flow diagram. This is a patient who needed to receive a vaccination, and the patient is identified. Again, there's an assessment done that the patient is eligible for the vaccine. The vaccine is prescribed, the vaccine is administered, it is documented, and then it is communicated with primary care, for example. In this case, this team identified that they failed to identify the patient who should be eligible for that vaccine. Therefore, they needed to start there to identify where they can make the process more reliable.
Right. So yeah, we're not going to talk about the first one there. Just thinking about any sort of daily processes in your areas. Can you think of sort of any processes which could be improved? And then we could probably take that as an example. You guys got any processes?
I work in a day program for young people, so I suppose in a similar way to a school, we have to kind of have a sense of who's here for the day, who's meant to be here.
Mm-hmm.
And if they have or haven't turned up, then we bring the families and
Okay.
check out where they are.
Mm.
So I guess in New Zealand, at the worst end of that, the kid's been in like some sort of peril and the school didn't ring the family early enough.
Mm.
And in the lower end, they're sick and the parents forgot to ring.
Yeah.
So we're kind of aware of that, but sometimes you get busy in the work day and you don't end up ringing the family until later in the day. So I guess, yeah, that's probably a process we could tighten up.
Yeah, that's a good idea, and that's a good example. So your process is that probably the first box in that flow diagram would be knowing who is expected to come that day. So you need a list of people that you're expecting to come that day, and so that the first process would be in making sure that that list is up to date in some way. And then the next one is, next process would be checking people off against that list. And then the next process after that would be identifying those who are absent, who were expected. And then after that would be then the process for following up on those absences. And that could be a number of different things that could happen. But, and so I guess in that example, if you don't have an accurate list at the beginning, then the other processes will not work. So that in taking that example, that's where you might start. Yeah. And then you mentioned in your example how if things at work get busy, that you might not actually get round to following up those absences till a lot later. And so that's an example of human factors, isn't it? It's like maybe you were going to ring them in the next 5 minutes, but then you got distracted and you forgot exactly. So what you've been relying on is human memory, somebody just reminding. So is there other things that you can do to not solely rely on memory. Is there a visual cue? Is there something that will be there to remind them until it gets done? So actually, I've got an example of that, like a reminder. So at home, we have a spa pool, and once we use the spa pool, we have to put some chlorine in it and let it clean itself. And whilst that's happening, the covers need to be off so that the chlorine can evaporate. So that usually takes 20 minutes, and I don't want to stand there watching that happen. So I leave and go back in the house and do whatever I want, and then I forget. And then the worst time, I remember 2 days later, and the spa temperature was very low, and I'd obviously jacked up my electricity bill during that 2-day period. So I thought, this is not good. I've got to have a better way of remembering. So then the next thing I did was I said, okay, I'm going to put an alarm on my phone, a timer on my phone when I put the chlorine in. And then I tried that, and so far it's a bit better, but there's still mistakes. And the mistake is one time, quite often I forget to do the alarm on my phone. Or if I do remember to do the alarm on my phone, it then goes off while I'm in the middle of something else, like cooking. And so I turn the alarm off, thinking, okay, I'll remember to do it as soon as I finish this cooking, and then I forget. So that's not good enough still. So my next idea is to actually get a lanyard, and I put the lanyard on top of the bucket of chlorine. So when I go to put the chlorine in, I put the lanyard on my neck. I put the chlorine in, and I keep that lanyard on my neck until that pool cover is closed. So then if I forget to go back, at least by the time I go to bed that night and I go to take off my lanyard, I go, oh, this is not supposed to be on my neck. It's supposed to be down in the pool room. So maybe that is that will be a better way of reminding myself when to do it. So you can think of reminders in that sort of way: alarms, visual cues, physical things that are there to remind you, but also not getting in the way. So the phone alarm was getting in the way. When it went off, it was getting in the way of what I was doing. So then I just wanted to turn it off and get rid of it. So yeah, if you could think in your situation there of some sort of a reminder that would be there so that when staff do have a chance to follow up, that it's actually done and not forgotten about until somebody remembers. So anyway, any questions? Great. Okay, we'll leave it at that for now, but that's a good introduction to human factors. Any problems with the course, do let me know. And I hope you enjoy this topic. I found it fascinating. Okay, cheerio. Bye.
Thanks so much, James.
You're welcome.
See ya.
Bye.